psychiatric disorders. With Psyked, we want to bring expert talks on varied topics from AI and healthcare to the latest research on neuroscience and psychiatry to clinicians. Our goal is to elevate the conversation on how technology can help us make rapid advances in improving mental health for everyone. In today's session, we'll be covering the ICD and DSM classificatory systems and the research framework RDoC. Joining us today is Dr. Abhimanyu Chandak, consulting psychiatrist at BrainSightAI. He finished his MBBS in 2016 from Jawaharlal Nehru Medical College, Belgaum, and then he did his MD in psychiatry from JSS Medical College and Hospital, Mysore in 2020. So a few house rules before we begin. If you have any questions, please share it with us in the comments. We'll take the questions towards the end. We have a 45-minute session planned for you. Dr. Abhimanyu will take us through the presentation for the first 20 minutes, and that'll be followed by questions from the moderator. And then we'll take questions from the audience in the last 20 minutes. And Dr. Abhimanyu will share his email ID with you at the end of the session. So if you have any follow-up questions, you can reach out to him directly. Yeah, that's it. So I invite Dr. Abhimanyu to take over now.
Thank you, Kriti. Thank you for those kind words. So I'd like to thank BrainSight for this opportunity and also for giving me this forum to present this topic. So I think let's start.
Yeah.
Yeah. So I'll just share my screen. Just give me a minute. All right. So is my screen visible to everyone?
Yes.
Yes.
Yeah. Okay. So what we're going to be doing is we're going to be covering classification systems in psychiatry, and we're going to be focusing more towards the RDoC section of the presentation, with a brief history of what ICD-10, DSM-5, ICD-11 look like right now. So I'm going to be covering this presentation with respect to why are classificatory systems so important, and especially when it comes to a subject like psychiatry. A little bit of history, because unless we know the history, we cannot know where we are headed to next. What are the current classificatory systems? Why do we need an update? And what's coming up next? So classificatory systems have been important in all sciences, right? That's unarguable. So what exactly is classification? So classification is basically a group of diagnoses which are grouped together by relatedness. And this is usually done, or the guidelines are usually presented by giving us some sort of criteria. Now, these criteria are said to be rules to be followed to make a diagnosis, but they usually end up being more of guidelines that are followed to reach a diagnosis. So as we say, that diagnosis is prognosis. So unless we know unless we're able to give a diagnosis to a patient, it's very difficult in understanding what the course of the illness will be, where this illness is progressing to, what the outcomes might be, or even what the functionality of this patient might be. So that basically is even more important in psychiatry with the prediction aspect as to where is this person going to go in the next few years. Now the communication aspect comes in where we don't want to harm or cause harm, miscommunication either between two doctors, either a doctor and a patient, or even at the public domain. So unless we have a common set of guidelines or a common set of diagnostic criteria, which can maintain a uniformity all throughout varying cultures and varying societies, there is going to be some amount of miscommunication that's happening from the diagnostic spectrum. The other thing is that there is a lack or deficiency of basically these biological and objective markers. So psychiatry is one of those subjects where we hardly look at the organ that we are trying to treat. So there are very few physical symptoms. There are rarely any blood tests done. There's rarely any neuroimaging done, especially in India. So when we are not looking at these things, what do we use to diagnose them? And that's where these diagnostic guidelines come through. The third thing is the subjectivity of the phenomenon. So when we are using symptoms and signs, now each symptom and each sign can be interpreted differently by the patient themselves, can be interpreted differently by the doctor they are speaking to, can be interpreted differently by the family members. So how do we maintain this communication between the patient and the doctor so that everyone reaches a common conclusion? That's where the diagnostic guidelines come in again. Now, if you can see that it causes so much of trouble in just simple diagnosis and prognosis, imagine what it does to the research and the scientific domain. Your research and your research studies are usually done with the aim of being able to generalize these results, put it out into the sort of public domain that this is what is happening and this is the reason it's happening. So unless there's a uniformity in how the diagnosis has been made for research, we are going to have difficulty in generalizing those results. So a little bit of history. So mental illnesses have been here as long as civilization has been here. Unfortunately, we are still fighting with respect to the diagnostic guidelines as to what should be used for a diagnosis and what should not be used for a diagnosis. But we have fortunately stopped drilling holes into people's heads for every little thing now. So it all started in the 1800s in Europe with these two gentlemen here, Karl Hasper and Emil Kraepelin. And these two basically just wanted a way to say that there is a distinct class of illnesses which are different from physical illnesses. So Hasper said that there is something called a psychosis that exists, and Kraepelin basically gave terms to differentiate psychiatric illnesses from dementia. His basic focus was, let's differentiate it from dementia. So he gave dementia precox, which is the most basic understanding of schizophrenia. He gave the manic depressive psychosis, and lastly, he gave the psychopathic personalities. So then came in the Americans. So the Americans started off giving the DSM, which is the Diagnostic and Statistical Manual. So the first DSM that came in 1952, and this DSM actually contained a lot of medical and neurological illnesses as well, and it was more an adaptation of the European system that existed at that time. The first paradigm change came in DSM-3, where now they had 265 mental illnesses, and they started to use more of the descriptive criteria and move more towards a research from a research background rather than just a phenomenological background. Then the next major change came with DSM-4, where they started to adopt a spectrum look towards mental illnesses and towards psychiatric illnesses. And in DSM-5 now, which came in 2013, there are over 400 diagnoses that are there in DSM-5. And it looks at things from developmental, cultural backgrounds, talk about the severity of each illness, gives you the distinction to make that, gives you the distinction to tell that, what kind of, how long the illness has been present. So we'll talk about DSM-5 when we come to the current classification system. The rest of the world follows the ICD, which is the International Classification of Diseases, although it was not always called that. And this is given by the World Health Organization. So the first one came in 1893, but the separate category of mental illnesses was added in the ICD-6 in 1948, following which the next major change came in ICD-9, where they started to use narrative descriptions. And within 15 years, they moved on to ICD-10, which is what we currently use. So ICD-10, again, we'll look at it when we talk about the current classificatory systems, but ICD-10, as you can see, has been here for almost 30 years. And ICD-11 is still coming, it's not here yet. So the current classificatory systems, basically the ones that are used right now are DSM-5 and ICD-10. So just sort of to make a distinction between what changes have occurred across from the previous ones. So DSM, as we know, is only for mental illnesses. It covers only mental illnesses and nothing else, whereas the International Classification of Diseases covers everything from medical disorders to psychiatric disorders to accidents, injuries, to social issues, everything. So that's one difference. The other difference that came in was that DSM-5 started looking at it from a dimensional approach, but also adding certain categorical concepts. So when we talk about dimensional and categorical, so categorical is basically just a yes or a no. So the disease is present, the disease is absent. That's it. That's all it talks about. And that's what ICD-10 still does. It gives you diagnostic guidelines and says that if this is present, there is a disorder. If it is not present, this is not a disorder. Unfortunately, psychiatry doesn't work that way. There's always going to be, as I said, there's so much of subjectivity. So there's always going to be sort of maybe one diagnostic guideline is missing for this patient. So that does not mean that the patient does not have a disorder. And that's where the dimensional aspect comes into. The DSM-4 tried to introduce this multi-axial system, but then again realized that that doesn't work. It's better to give multiple diagnoses than look at it from a multi-axial system. The difference between DSM and ICD, and this goes on to ICD-11 also, is that DSM still uses just a numerical coding, which, sort of limits the number of diagnoses that it can give under a certain this thing without making it very vast and very complicated, the numbers. Whereas ICD uses an alphanumerical, which sort of simplifies and makes it a little easier to, remember the codes. ICD-10 is the only classification right now that actually gives space for adding new disorders as and when they are discovered without having much of a change. So what happened, right? So what happened and why do we need an update? So first thing is that there are terms and there are diagnoses which are actually out of date, which are still present in ICD-10. DSM-5, yes, maybe has caught up, but then again, in the past 7 years, a lot of things have changed. But ICD-10 being 30 years old still uses some terminologies, which may not be ethically right in the current society. The second thing is that DSM and ICD have always been sort of competing with each other. And they've tried to get into sync, but every time DSM comes up, ICD changes, ICD comes up, DSM changes. But finally, I think with ICD-11 coming up, we are at a point where DSM-5 and ICD-11 are on the same thought process. They follow the same flow. They follow the same, sort of distinctions between classification. So we are getting there. Then, as I said, the use of right terminologies, because of it's out of date, there is a need for dimensional approach. Again, as I said, that the psychiatric illnesses are not that distinct. You can't just say that this is it. This is where the psychiatric illness starts. And lastly, none of the diagnostic guidelines right now actually talk about how this disorder is happening. Like, you have a classification, but why is it classified this way? So why is there depression? There is no tangible feature over there that tells you. It's just symptoms. So what's coming up next? So the first thing we need to understand is that DSM-5 is here to stay. There has been no talk of DSM-6, there has been no talk of DSM being even upgraded, a TR version of DSM-5 coming. That is not there anywhere. The ICD-11 is actually available on the WHO website for everyone to see. And currently what they have given is based on mortality and morbidity statistics, and it is out for field trials. So it came in 2017 and it's still undergoing field trials and soon to come out, but they have not given us an exact date. So lastly, coming to the research domain criteria. Now these research domain criteria was given by the National Institute of Mental Health. And they actually started this even before DSM-5 came. So they started this research in 2007, if I'm not wrong. So they started this in 2007. And so with the RDoC, what they tried to do is, it's not a diagnostic guideline, right? It's something of a research framework that looks to investigate and sort of integrate multiple different domains across the disorders and understand them from a perspective of biology, behavior, psychology, social, different tests that are to be conducted. And it does this by designing a matrix. So now let's have a look at the RDoC matrix. So now the RDoC matrix basically is columns and rows. So the rows now contain various rows as you can see here, they contain these domains. Now these domains are placed in a longitudinal manner, and under them they contain constructs and they contain some subconstructs. So each disorder can be understood with respect to what changes happen in these domains and in the constructs and subconstructs. Each of these individual domains, constructs and subconstructs can further be understood under these units of analysis. Now these units of analysis, as you can see, these are the biological parts. The circuits also have certain behavioral parts which come here, and the physiology again becomes biological. Self-report can be what the patient feels. All of these are affected by the environment, and the neurodevelopment anyway plays a role throughout any illness. So just an example of how the matrix might be. So this is how the matrix might look for a disorder. So say you pick up any disorder. So you look at each of these domains, the negative valence system, the positive valence system, the cognitive systems, and each of these domains, you look under each of these units. They have also added another unit here, which is called the paradigms, which is basically the tests that are done to look at each construct and subconstruct. Now, a lot of these constructs have also gotten subconstructs. There are a few more additions of constructs that have also happened across different things. So it's still an evolving thing which is happening. Now, why is RDoC needed? Why do you feel that, why do we feel that these guidelines are not yet enough. So one thing is that there's so much of subjectivity and heterogeneity. So once you are able to give someone tangible proof that these are the genetic changes, these are the molecular changes, these are the behavioral changes, these are the things that are affected, and you're able to tell a patient or say a caregiver that these are the problems that you are facing and these are the reasons why, there's better acceptance towards it, a better understanding of it. You can also use this to sort of understand what the overlap between the comorbidities is. We already know that, a lot of disorders exist together, like depression and OCD exist together many a times. But why do they exist together? We only have a psychological understanding of this. Once we get a biological understanding of this to a greater extent, we do have some amount, but to a greater extent, will again, help us to push the research forward. The third thing is that, we still recruit according to symptoms or according to diagnosis. We don't recruit according to why it is happening or how it is happening. And that restricts our, number of patients or the type of patients that we pick up here. Lastly, this will all again help us in looking at things from a dimensional aspect, saying that, okay, say this number of, or this amount of behavior, this percentage of behavior change needs to happen, or this percentage of molecules need to be changed, or say, these many circuits in these many areas need to be affected for the disorder to appear. Before that, it's not appear. So it gives us an understanding of why the dimensional approach is there and integrates the categorical approach into that. Just before I conclude and give away my summary points. So these guys at BrainSight, as you can see, they are basically trying to use artificial intelligence on fMRIs, structural MRIs, and digital phenotypes to give a lot of precision to diagnosis and prognosis for various illnesses. And as I just talked about, like this completely integrates with the RDoC system. And this will help psychiatrists provide a more holistic view as well as a more holistic sort of approach towards treatment of these disorders. Just final takeaway points. As I said, classificatory systems are important in medicine, any science, but especially so in psychiatry. These are basically guidelines which help a clinician make a diagnosis and help in maintaining uniformity and in both diagnosis as well as communication. Currently, DSM-5 and ICD-10 are the classificatory systems that are in use, but ICD-11 is coming soon. And the RDoC is not here to replace any diagnostic guidelines, but to help us understand better what is problems and make it a little more comprehensive. Yeah, so thank you. And this is my email ID. You can contact me on any of these. Thank you.
Thank you so much, Dr. Abhimanyu, for your lovely presentation. So it looks like we actually only have 5 minutes remaining for the meeting. So I'll just ask a couple of questions that we have from the moderator and from the audience. And then if you have any additional questions, you can reach out to Dr. Abhimanyu on his email ID. So one question I had, Dr. Abhimanyu, is you mentioned that RDoC is a research framework and it's not used clinically, but so then what would be the more practical applications of this framework apart from informing research?
So, so RDoC is actually being, or as it was proposed as something that could help us understand the disorder from one side. So you can use that understanding to sort of put it across to patients. So from a therapeutic perspective, you can explain the patient that, these are the reasons because of which you are having these problems, and this is what your prognosis looks like. And so based on the number of sort of domains involved or the what units of analysis show that, okay, these are the regions that are involved. So that's one thing, and you can use it in therapy. The other thing is that it can help us, sort of make better distinctions when it comes to diagnostic guidelines. There is still so much of overlap between disorders. So once we understand, again, across the domains, that how these are distinct or how they overlap even more, we might find some disorders which are even more overlapping, or we might find something which we think is overlapping but is actually having a lot of distinction, right? So from a diagnostic perspective, that comes in. From a therapeutic perspective, what it can do is say you find that there is a certain kind of depression where only some genetic structures are involved, or say some circuits are involved, but in a different kind of depression, different circuits are involved, different genetics is involved. You can talk about what is called as, the pharmacological aspect, that what kind of medication would help which kind of depression or which kind of disorder, even subcategories within that. So these are the three places that that I can think of right off the top of my head that this would help.
Yeah. So another question, from the audience actually, by Dr. Arama Sheikh, asks, which classificatory system is more suitable for the Indian population, ICD or DSM?
So what happens is that usually when a classification system is made, it is sent out for field trials, right? So DSM has not been field tried in India or anywhere else in the world except for US. So its classification is mostly US based, whereas ICD has been field tried everywhere else. So while ICD is used more commonly in India, there is actually no distinction, because as I said, the ICD level is moving to integrate towards into DSM. So it follows the same thing, it follows a similar thing, but the more commonly one used in India is ICD. You can use whichever you are comfortable with. There is no real distinction as such. Okay.
Thank you so much. I think the meeting time is running out. So sorry about that. Thank you so much for spending your Friday evening with us. Please share your feedback and let us know what topic you would like us to discuss next. Do connect with us on LinkedIn, Instagram, and Twitter at BrainSightAI. And if you have any questions, then you can email Dr. Abhimanyu on his email ID. Thank you.